So this is back to the patient that we had presented at the beginning of the talk. The 41-year-old, 8 weeks, large BMI, had a PE last pregnancy, came in with shortness of breath and chest pain. Workup was negative, treated with Lovenox through 6 weeks of postpartum phase, and additionally had a mom. Her mother had passed away from a PE at age 52. Risk factors, obviously, the history of a PE, obesity, and then the family history that's terrible. It wasn't associated with pregnancy, but it certainly makes one wonder whether there had been a thrombophilia, but her workup was negative for that. So how would you manage this patient? Would you fully anticoagulate her or give her either intermediate prophylaxis or the baseline prophylaxis? I'm just curious to see what other folks would think.
So what we can do, because we are recording this, as I'm recording, we can't see who's talking at all. So if you feel comfortable unmuting, you can just unmute and talk because it's being recorded. If you don't feel comfortable having your voice heard, you can just chat, and I'm not going to identify who is saying what at all. I'll just read out the question. So no one at all will be identified for who's sharing, just so you know.
And even if I can just have a couple of people tell me what they think.
So I'm looking at the chat now. And again, if you're comfortable, just unmute.
I would do 1 mg per gig once a day.
Okay, so that intermediate
Intermediate dosing is as long as not an acute clot.
I agree with Dr. Adams.
Way to call out Dr. Adams' name, Dr. Mather.
It's all right.
We won't do that to anyone else. It's okay.
Anybody else have a strong feeling one way or another? Because I would tend to do that as well. Push up the next slide.
Okay.
So we actually counseled the patient, and the patient felt strongly that she wanted therapeutic dosing. We counseled her on 1 milligram per kg once a day. She wanted to take it twice a day, which is certainly within the realm of appropriateness. So that is what we prescribed with her. But I agree with what others have said. But by the data, low dose prophylaxis falls within the realm of appropriateness as well. A prescription was sent to her pharmacy. The patient came back 2 weeks later. Insurance declined to pay for it. And for those who don't understand this, Lovenox is very expensive. It's not something like you can just pay for out of pocket. Most people can't just do that. It required a prior authorization, but the office was not contacted to state that there was needed a PA.
How involved and helpful is Medicaid in this topic?
Now they're better than they used to be, because if there is a patient that if they decline it, they will send to the office or call the office. But sometimes they don't either. Depends on which MCO it is. Some are better than others. Go on, push the next one up. I think this is kind of the problem here. The patient comes back 2 weeks later. Now she's 10 weeks gestational age, no Lovenox. And she didn't call the office. She just said, the insurance company said I didn't need it. They said, but I really want to take it. How can we go about getting it approved? So the PA was sent. So this is a fallout for the office, honestly, not following up with the patient. And it's a fallout with the pharmacy, and it's a fallout with the insurance company, frankly, that nobody called. So she leaves this appointment 2 weeks later, and it just keeps getting worse. A PA was sent. It was approved 1 week later. She goes to pick it up, and the pharmacy doesn't have it in stock. And the pharmacy just does, they don't give her a solution. We'll have it in the next week. Okay, so they don't say go to the next pharmacy or go across the street to another place. Go ahead, and this is just a Swiss cheese thing. So this is patient comes back 2 weeks later. Now she's 12 weeks. We didn't know that she wasn't taking the Lovenox. And she's frustrated, and we make sure that it goes to a pharmacy, that they have it. We send the prescription to another pharmacy, and she says, I can't pick it up for another couple of days. She's always by herself. She's working. She's busy. She's got lots of stuff going on. And next slide. And 2 days later, one day before she was going to pick the prescription up, she has a fatal pulmonary embolus. It's a tragic case. It's a series of unfortunate events. First bad is on our office, not having a navigator to call these patients to make sure they're on their medicine. Were you able to pick it up? Are you taking it? Are you having any problems? The lack of patient urgency too. Is it a lack of understanding? Making sure that the patient really gets why we feel like she needs to be on some dose of prophylaxis to prevent a clot. And then the lack of involvement of insurance companies, pharmacy. Why don't you just call the doc that sent the prescription in? And again, the office. I mean, it's on us too. It's just a system-wide problem that leads to a preventable death. Yeah, it was preventable. We've got to do a better job with patient education, make sure that they're advocates for themselves. Family education. I want a family member with these patients to be able to tell them, sweetie, you need to call your doctor if you can't get the prescription. They don't know you're not getting it. And then again, the system issues with the office, the insurance, the pharmacy, and the very jobs that we end up having to slice and dice because of limited healthcare dollars, or those positions that help prevent these things from happening. Nurse navigation, the use of community health workers, social workers in the office who follow up with these patients. These systems pieces are so critical to make sure that the right information is getting to these patients and they're doing what we suggest to them to do to enhance their healthcare outcomes. There's so much to do to prevent the Swiss cheese effect. I hate to leave it on such a downer, but I mean, this is critical. This is one case, and this happens more than we would want to believe. But we have to partner with our community. We have to provide education. Those are chief needs that can help get to these patients. It's not all just the healthcare institution and our healthcare providers and systems here in the office, but it's all of our shareholders that we have in the community and in our insurance world and elsewhere. So anyway, I'll stop with that. Happy to